So this lecture is going to focus on ACE inhibitors in relation to kidney disease. Learning objectives. So by kidney disease, we're really kind of talking about chronic kidney disease, which is best described by a reduction in GFR. Typically, we associate kidney disease with diabetes and hypertension, specifically both of those being comorbid conditions. When this manifests, there are numerous complications. First and foremost, we can see excess protein in the urine, which is most likely due to a leaky glomerulus. Obviously, we'll see altered sodium and water balance, the production of hyperkalemia, the production of metabolic acidosis, and in some cases anemias and changes to mineral homeostasis affecting bone density. In terms of the treatment, the rationale is to delay or prevent the progression of CKD, and our target is going to be to use the renin-angiotensin-aldosterone system inhibiting drugs to basically reduce protein in the urine. That's one of the telltale signs that this is occurring, and we can best accomplish this by using either ACE inhibitors or ARBs. Just to recap, ACE inhibitors have a profound effect because they target the outcome of angiotensin II. Angiotensin II has several mechanisms, many of which are responsible for altering total peripheral resistance, but also altering renal function and renal physiology, as well as cardiac structure. In terms of angiotensin II in and of itself, it's a very potent vasoconstrictor, and in fact, it's actually more potent than norepinephrine in terms of eliciting a rise in blood pressure. It also indirectly affects norepinephrine release and reuptake. It affects sodium and potassium activity within the nephron, which we'll talk about from the physiology standpoint in the next two cases. And it also alters local cardiac physiology in terms of the production of growth factors and the rearrangement of extracellular matrix proteins. And so angiotensin II can result in a very rapid pressor response through these mechanisms here, or a very slow pressor response through these mechanisms. And so it has a really tight control in terms of total peripheral resistance, as well as hypertrophy and cardiac remodeling at the cardiomyocyte level. So, systemic effects are quite numerous. We're going to focus on the renal component. Angiotensin II, in terms of renal physiology, can heavily influence GFR. And so you can see a constriction of the afferent arterioles by the reduction of a reduced intraglomerular pressure within the glomerulus. That'll reduce GFR. We can see a contraction of the mesangial cells that reduces the surface area inside the glomerulus, which will ultimately reduce GFR. And these first two are essentially normal kind of physiologic outcomes. You can see a constriction of the efferent arterioles, which will of course produce an increase in the intraglomerular pressure and increase GFR. This is typically only seen in pathological conditions. The classic example would be something like renal artery hypotension or renal artery stenosis or something like that, where this effect on the efferent arterioles tends to predominate. And this is best depicted over here. This is the reason that ACE inhibitors are actually contraindicated in patients that have bilateral renal artery stenosis. And so remember, angiotensin II obviously has effects on both the afferent and the efferent, but in pathological states it is quite more potent on the efferent side, which can be dangerous. And so angiotensin II, of course, is the determinant factor of the efferent vasoconstriction. And then angiotensin II obviously helps maintain GFR when renal perfusion is low, and that's kind of the key. And so patients that have volume depletion, elderly patients with really exacerbated CHF, blocking angiotensin II in these particular cases is going to be a bad idea and will actually produce or exacerbate renal failure. So that's one thing to kind of keep in mind.